So hi guys, welcome everyone. So on the last session of the PW MedEd Farre for the upcoming theory exams for the final prop, we are going to discuss the questions from endocrinology. So now we have lined up 4 or 5 important questions from endocrinology, and of course within that there will be embedded sub questions or small topics which we will cover. Okay. So we'll start with the first question, which is of course based on the most common topic, which is diabetes. Right? We are in the diabetes capital of the world, so ये question तो बनता है to appear in the examination. Okay. So questions on diabetes primarily focus on asking you to enumerate the criteria laid down by the American Diabetes Association for the diagnosis of diabetes mellitus. Sometimes questions may ask you to focus more on the classification, and majority of the questions also ask you to write about the pharmacological management of the diabetes mellitus or classification of the drugs used for diabetes, right? So let's begin. So here is our question. Enumerate the diagnostic criteria for diabetes mellitus, classify DM, describe clinical features and management, right? Okay. So as I've told you multiple times, whenever we have a question, we should always open with the definition, even if the examiner has not asked us to define. That 30 to 40 seconds that we spend on writing actually makes the answer appear more pleasing and opens up the right avenues for us to build the answer. Okay, so what is diabetes mellitus? Diabetes mellitus is not a single entity, right? Because we know there is type 1, type 2, gestational, MODY, LADA, the list goes on. So I will define it as a group of disorders which are characterized by chronic hyperglycemia. So the first important word that is required here is that we are mentioning that it is not a single entity, it's a group of disorder. Second thing, I'm using the term chronic hyperglycemia, right? Sometimes during stressful events or during infections, our sugar may shoot up, but that does not qualify to be called as diabetes. We'll call it as stress hyperglycemia, right? So it has to be chronic hyperglycemia due to, again, I'm giving you an example. If there is someone who is chronically bedridden and is nutritionally dependent on parenteral nutrition, and the parenteral nutrition itself may cause hyperglycemia, and if I'm using total parenteral nutrition for a long period, it can cause chronic hyperglycemia. Should I call that as diabetes? No. So we will call it as diabetes when this chronic hyperglycemia is due to either deficiency of insulin or impaired insulin action. Okay, so we know that when there is impaired insulin action, we are going to call it as type 2 diabetes mellitus, and when there is deficiency of insulin, we are going to call it as type 1 diabetes mellitus. So what clinical features these patients present with? So remember, majority of the diabetes patients present in asymptomatic state, right? So most cases remain asymptomatic for several years. So they get recognized when we screen them for several years. If someone presents with symptoms of diabetes mellitus, it already means that the degree of hyperglycemia is very high. So if I'm expecting symptoms, what symptoms we're expecting? Polyuria, polyphagia, and polydipsia. 3 P's of diabetes mellitus: polyuria, polyphagia, and polydipsia. Apart from these symptoms, patients may have complications of diabetes, which we will discuss later. Okay, now before I go to the further discussion of the questions, why do we get polyuria, polyphagia, and polydipsia in diabetes mellitus? Okay, we have studied about 2 entities which start with diabetes. One is diabetes mellitus, the other one is called as diabetes insipidus, right? So both of them are called as diabetes, one mellitus and insipidus. Why so? Why am I using the term diabetes for 2 entities which are not at all related? Well, yesteryears, when our ancestors scientists were analyzing people having polyuria, and they were trying to figure out what could be the cause for people with polyuria, they noticed that some people with polyuria, their urine tastes sweet, and some people with polyuria, their urine tastes very bland. Insipid means tasteless or bland. So people with diabetes insipidus actually have polyuria, which is very dilute and it tastes bland. People with diabetes mellitus, they had polyuria, and because there is excretion of urine, it used to taste sweet, right? So mellitus means sweet. That is how they categorized people with polyuria as the one having insipid, tasteless urine as DI, and the one having sweet urine as the mellitus. Okay. Now we know what is the reason for sweet urine, because there is excretion of glucose in urine. Blood level is high, kidney is not able to reabsorb all of that. There is saturation of SGLT2, so we lose a lot of that excess glucose in urine. So urine is becoming sweet. But as we lose glucose, glucose is an osmotically active substance, right? Remember, there is a formula for the serum osmolality which includes sodium, bun, and glucose. So glucose is an important contributor to osmolality. So if I excrete glucose, being an osmotically active substance, it will also drag water along with it. So that glucoseuria causes polyuria. And as I start losing water, what will happen to my blood or serum? I'm losing water from the serum. So serum is becoming concentrated. So there will be increase in serum osmolality. And we have a thirst center in the brain to regulate the serum osmolality. That will get triggered, right? As the blood is becoming concentrated, I need to add water into it. So the thirst mechanism will get triggered. I'll start drinking water. That is what causes polyphagia. Okay. Polydipsia, that is increased thirst. Then they will have polyphagia, that is increased hunger. Why should someone have increased hunger if they are having diabetes mellitus? Well, the first thing that we need to know is that if I ask you what is the function of insulin, you're free to say, sir, it is supposed to reduce your blood glucose levels. True, but there is also an equally important function of insulin. Insulin is supposed to help cells uptake or utilize the glucose that is there in the blood. So if there is insulin deficiency or insulin inaction, cells will not be able to take up the glucose from the blood. So if cells are deprived of glucose, they will send signaling mechanisms, signaling molecules, which will stimulate the appetite, because cells are not getting, your blood level of glucose is very high, but cells are not able to make use of it because either insulin is not working or insulin is not there. So the signaling mechanisms concerned with appetite get activated, and this patient will keep feeling hungry. So he will eat, blood levels of sugar will go high, but still this high sugar is not easily usable to the cells or tissues because of insulin's inaction, right? So we get these 3 P's of diabetes mellitus. Okay. But because majority of the patients are asymptomatic, there is a need for a screening strategy, because it's not right to recognize when they present with the 3 P's, because by that time the degree of hyperglycemia will be very high. Patient would have spent several years with hyperglycemia, and that hyperglycemia would have already caused organ damage. So better is that I screen in asymptomatic stage itself and control it, so that my patients do not come to me later with these 3 P's, right? So when is the screening recommended? So if there is a risk factor for diabetes or clinical features, then screen at the time of presentation. Like someone presented with polyuria, polyphagia, of course, on the day of presentation itself, I will screen for diabetes, right? But for asymptomatic individuals who do not have risk factors, right? For general population, when should I screen? The American Diabetes Association recommends that for general population, the screening should begin at 45 years of age, right? At 45 years of age, and if that is normal, there is no diabetes, then every 3 years it recommends that we should be screening. If no DM, further screening at 3 yearly intervals. Further screening at 3 yearly intervals means once in 3 years we should be screening them for diabetes. Okay, so now we know when to screen. For general population, we should start screening at 45. If they are found diabetic at 45, of course I will try to manage them. If they are non-diabetic, 48, 51, every 3-year interval I will start screening. But if anyone has risk factors, what are the risk factors for diabetes? Obesity, family history, sedentary lifestyle, right? Use of glucocorticoids for a prolonged period, some immunosuppressants like cyclosporine, which is known to cause hyperglycemia and diabetes. So if there are risk factors, or if patient already has clinical features suggestive of diabetes, then at the time of presentation itself, I should screen. Okay. Now, let us say we got the test done because we suspected patient as having diabetes, or we did a routine screening. Now, how will I interpret that test so that I can make a diagnosis of diabetes? So to make the diagnosis of diabetes, we have few parameters laid out. The first one is fasting plasma glucose, that is fasting blood glucose, or you can say FBS, fasting plasma glucose. In the exam, what is expected from you to write about FPG? You should write for how many hours patient should be fasting and values above which the diabetes can be diagnosed, right? So here, fasting is equal to no calorie intake for 8 hours. No calorie intake for 8 hours means patient should not have taken any calorie containing food for 8 hours. Water, no problem. Okay. If this fasting plasma glucose is more than or equal to 126 milligrams per deciliter, then you can say patient is having diabetes. Okay. The second one is postprandial, that is 2 hours after taking food. 2-hour postprandial plasma glucose. 2-hour postprandial plasma glucose. Okay. Now here, when I say postprandial, can I say patient go and eat whatever you want and then 2 hours later come back and let me check your sugar? No, because blood glucose level is always a function of the glucose load and the glycemic index of the food. So if I go out and eat half a kg laddu and then come back after 2 hours for checking blood glucose level, of course it will be quite high, even in a relatively healthy individual. So even the calorie intake here has to be standardized. So that again it's going to be oral glucose tolerance test. And what do we use in oral glucose tolerance test? 75 grams of anhydrous glucose. So patient is not asked to eat here. We ask him to take 75 grams of anhydrous glucose dissolved in water, and then 2 hours later we will check the blood glucose. Okay. So if that is more than or equal to 200 milligrams per deciliter, patient will be called as having diabetes. This is one of the tests which is routinely interpreted or done wrongly in clinical practice, because I've seen a lot of GPs and the alternate medicine practitioners just ask them to get a 2-hour postprandial blood glucose. They go to lab after taking breakfast or something from some nearby restaurant and then get the blood glucose level done. Sometimes they may be taking just one idli and that does not have sufficient glycemic load, right? One idli is no way equivalent to 75 grams of glucose. So even if they're having significant postprandial rise in glucose, it will not show up on that test. And some people may go out and have some nice desserts and sweets and then come back and it may give you a falsely positive result, right? So it has to be standardized. We should keep it in mind. The third one is based on HbA1c. HbA1c more than or equal to 6.5%. More than or equal to 6.5%. The fourth one is important. We need to write it more precisely. That is random blood glucose, RBG or RBS, random blood sugar or random blood glucose. If it is more than or equal to 200 milligrams per deciliter with, this part is very, very important, with signs or symptoms of diabetes mellitus, symptoms of DM. So if I just randomly do somebody's blood glucose level and let us say it is 200 plus, but he is asymptomatic, I cannot make a diagnosis of diabetes here. Those patients should again be subjected to these investigations to confirm it as diabetes, because depending on the food's glycemic load, sometimes we can have values more than 200, right? But if I have someone whose random blood sugar is 200 plus and he is having polyuria, polyphagia, polydipsia, or he presented with diabetic ketoacidosis or hyperosmolar hyperglycemic state, in that case I can make a diagnosis of diabetes without going for the fasting next day or HbA1c or the oral glucose tolerance test. Okay. Now in the question on diabetes, the diagnostic criteria, the numbers you can't afford to mess up. If you have messed up the numbers, examiners will not give you any marks for this section of the question, because diabetes is so common and every doctor is expected to know everything about diabetes regardless of the specialty. So we cannot afford to mess up the numbers. If I am the assessor or examiner, I will not give any marks if you do numbers little bit here and there. So you have to precisely by heart and remember. Okay. Now coming to the classification of diabetes. There are several ways of classifying it. The American Diabetes Association classification is a bit complex, not suitable for recreating in the theory-based exam. So we will adapt a simple strategy. We will classify the diabetes mellitus into type 1, type 2 gestational diabetes mellitus, and other specific types. Okay. So now first we will start with type 1. So what is the pathology in type 1? Type 1 is due to absolute insulin deficiency, right? It is due to absolute insulin deficiency. So there is decreased production of insulin. There is decreased production of insulin. Why? Again, that is due to beta cell which produces insulin, right? So there is destruction of beta cell. Now what can cause it? There are two possibilities. One, it can be autoimmune or it can be non-autoimmune. Non-autoimmune, we do not know the causes yet. 5% of type 1 diabetes mellitus can be non-autoimmune, 95% is going to be autoimmune. So based on that, we will classify type 1 diabetes mellitus into two groups. The type 1A and type 1B. Okay. So type 1A is autoimmune. Type 1B, we don't know what is the reason for the destruction of beta cells. So we will call it as idiopathic. Okay. And if it is autoimmune, then I should also mention what antibodies are responsible for the type 1 diabetes mellitus. So we have anti-glutamic acid decarboxylase antibodies. Then we have anti-islet cell antibodies. Okay. Then we have anti-ZNT8 antibodies. These are few of the antibodies that we can talk about, which are seen. Among them, as we know, the most common antibody is going to be anti-GAD antibody, and the most specific antibody is going to be anti-islet cell antibody. All of this description is not required in your theory exam, but for MCQs, it is important. Okay. So that is about type 1 diabetes mellitus. Okay. Now coming to type 2 diabetes mellitus, what is the mechanism here? It is due to increased insulin resistance, or you can also write saying it is due to decreased insulin sensitivity. So the defect here is in the insulin receptors. So it is the receptor defect. So either receptors are down regulated or they have become dysfunctional. The number of receptors has come down or they have become dysfunctional. That is the main mechanism in type 2 diabetes mellitus. Okay. Then gestational diabetes mellitus, the hormones that are produced during pregnancy, like human placental lactogen, they mimic or trigger the mechanism very similar to type 2 diabetes mellitus. So they decrease the insulin sensitivity. So in gestational diabetes mellitus, it is due to human placental lactogen and other hormones decreasing insulin sensitivity. So it is very similar to type 2 diabetes mellitus, and studies have shown that those who have gestational diabetes mellitus, they have high risk of progression to type 2, because what is the main mechanism? Insulin resistance, which is becoming little unmasked during pregnancy, but as such the patient is already at risk. Otherwise, not every female who is pregnant will develop gestational diabetes mellitus. Okay. Then we have certain other specific types. So what you should mention under other specific types? The first thing I want you to mention under other specific types is secondary diabetes. Secondary diabetes. It is secondary to something else. Examples we can quote is use of steroids, right? Long-term use of steroids causes diabetes, or pancreatitis, chronic pancreatitis causes destruction of the pancreas and can cause diabetes mellitus. So we all call these cases as secondary because they're secondary to some other disease. Okay. Then we have another category here, which is called as maturity onset diabetes in young. Maturity onset diabetes in young, where young individuals present with diabetes, in them neither they have antibody mediated beta cell destruction nor they have insulin resistance. They have the abnormalities in sensing the blood glucose. So pancreas cannot sense whether your blood glucose is appropriate or not. So they will not be able to release the insulin whenever the blood glucose level is high, because the sensor itself is defective. Right? So there are multiple types of MODY, MODY 1, 2, 3, 4, 5, 6, and the list goes on. You can mention those here. Right? So these are all other specific types. You can also add drug-induced diabetes mellitus, neonatal diabetes mellitus, and you can elaborate more if you want. This is the classification that I want you to write in the paper. Okay. Now, once we know the classification of diabetes mellitus, let us talk about the management. So management, because the mechanisms are different. Okay, we are not getting into the gestational diabetes mellitus or other rare types. GDM, we will leave it to OBG. We will address type 1 and type 2. Because the mechanisms are different, the management is also going to be different. So what is the problem in type 1? In type 1, there is insulin deficiency. So how would I treat? Can I give drugs which stimulate the beta cells to produce more insulin? No. Why? Beta cells are already destroyed. So I cannot squeeze more insulin out of the pancreas. Pancreatic beta cell mass is down. Only thing I can do is give insulin exogenously, externally. So for type 1 diabetes mellitus, there is no role of drugs which increase the insulin production from internal organ production. We have to give insulin externally. So the drug of choice for management of type 1 diabetes mellitus is always going to be insulin. Now we know that there are different types of insulin, right? We have short acting and long acting. So which one I should use here? Or do I need a combination? So what we have to understand is that if I take body's insulin levels and blood glucose levels and I plot it on a graph. So what we notice is, like let us say this is blood glucose level 70, okay, blood glucose level 70. So as long as blood glucose level is 70 throughout the day, I will have insulin being produced, okay. And if the blood glucose level goes above 70, so it is representing of blood glucose level 70. At 70, there is constant production of insulin. Anytime it is above 70, there is always a constant production of insulin. This is what we will call as basal insulin. Means at the basal level, body is producing insulin. But after that, if I take a meal, the blood glucose level increases, right? So whenever the blood glucose level is 70, there is production of insulin also. But when I take a meal, blood glucose level increases. So to counter that, even the insulin level increases so that the blood glucose level comes down. Again, if I take a meal, the blood glucose level is going to increase. So insulin will also increase to bring the blood glucose level. So what do I understand here? Insulin production never goes down to zero in physiological state, because physiological state body always try to keep the blood sugar level 70 plus. So as long as blood sugar level is 70 plus, there is constant release of some amount of insulin. And whenever I take food, blood glucose level rises, so insulin also rises. So I have to mimic this physiology. So how can I mimic? I have two broad categories of insulins: short acting, long acting. Long acting, they will act long period, but that will control, or that will be my replacement for the basal insulin which is produced as long as blood glucose level is 70 plus. But that will not be able to help me suddenly push up the insulin levels whenever I take food. So for food, I need a short acting. So we try to give short acting insulins before meal, and to have a basal insulin action, we will have long acting insulin. So what is preferred here? Currently preferred is combination of long acting insulins to mimic basal action. We will call it as basal insulin, plus short acting to cover meal induced blood glucose surge. Now whether you give them separately or a prefixed combination is a different story. Means I can ask the patient to take one long acting insulin, one dose in the morning, one dose in the night, so that during the night as well as day, his blood insulin levels are maintained. So basal function is taken care of. And then to counter the meal related surge, I will ask him to take a short acting insulin 15, 20 or 30 minutes before the meal. Or alternatively, what I can do is I can give a prefixed combination. Like you might have heard about something called as Mixtard 3070. Mixtard 3070. So in that, 30 is short acting, 70 is long acting. So when he takes one dose in the morning, he's getting 70 units or 70% of long acting insulin, which will act as the basal, and he's taking 30 units 30% or 30 units counterpart as short acting. So whatever breakfast related surge it will be there, this will be able to counter. Similarly, he will take a similar dose at night before the dinner. So then that will take care of his night need of basal insulin, and whatever is the dinner related surge, this short acting will take care of it. Okay. Ideally is to give them separately. If patient is not willing or it is difficult to educate the patient, then we can definitely give prefixed combinations. Okay. Now coming to type 2 diabetes. In type 2, insulin deficiency is a late manifestation. Starts with what problem? Starts with the insulin resistance. So in the initial stages for few years, there is hyperinsulinemia. Body is trying to produce more insulin to overcome the insulin resistance. So here giving insulin is not a right choice or right idea. What is a better idea? Try to increase the insulin sensitivity. Now, how can I increase the insulin sensitivity? First of all, why patients acquire insulin resistance? The answer to this lies in the lifestyle. So as people become more and more sedentary and consume calorie excess and start building fat in the body, insulin resistance starts evolving. So if patients start being mobile, start walking, doing exercises and start losing the weight, insulin resistance decreases. Many diabetics are able to reverse the diabetes by significantly reducing the weight and becoming more active. First and the strong suggestion for any diabetic would be lifestyle modification. So what are we going to recommend? We are going to definitely recommend weight loss of approximately 10% of body weight over 6 months. This significantly improves the insulin resistance. Second, exercise. Exercise wise, we are recommending moderate intensity aerobic exercise. Intensity aerobic exercises 150 minutes per week. 150 minutes per week. That means patient is asked to do at least 30 minutes of aerobic activity daily for 5 days. 2 days they can make it as rest day. 2 days they can make it as rest day. Okay. At least some of the patients, especially those who have mild degree of elevation in the fasting glucose or mild elevation in the HbA1c, they will be able to manage their blood glucose level with the lifestyle modifications and dietary modifications alone, right? So what diet we would recommend? We would recommend low glycemic index, right? Low glycemic load diet. In the sense, whatever carbs they are taking, the quantity of carbohydrates should be reduced, appropriate increase in protein and fat to compensate for the calories, and then whatever carbohydrate they are choosing should have low glycemic index, means it gets slowly digested and slowly absorbed so that the blood spike doesn't appear quickly. Okay. Now after that comes the pharmacological management. So what classes of drugs are available for me for the pharmacological management? First and the most commonly used class of drugs are bigonides. The example for that is metformin. Right. Example is metformin. Now, what is the mechanism of action of bigonides? Bigonides primarily increase the AMPK pathway activity. They stimulate the AMPK pathway. Okay. Now, does metformin have any side effects? Does metformin cause weight loss? Does metformin cause hypoglycemia? The answer is metformin may be weight neutral. Some studies show that metformin can cause weight loss, which is beneficial for a diabetic. What side effects do I expect? It does not cause hypoglycemia, because by activating AMPK pathway, it is only decreasing insulin resistance. Insulin resistance. It is not increasing insulin production, so it does not cause hypoglycemia. So the advantages of metformin is that it causes no hypoglycemia. It does not cause hypoglycemia. And there are recent studies which show that metformin has anti-aging properties, because studies have shown that this AMPK pathway, if AMPK pathway is slow, we tend to age faster. If AMPK pathway is active, we tend to age slower. So it has anti-aging properties. Anti-aging properties, and it is weight neutral. What do I mean by that? At least I can say that it doesn't cause weight gain. It is weight neutral. It does not cause weight gain. What are the side effects I'm concerned about metformin? Of course, hypoglycemia is not a side effect. Metformin is known to cause vitamin B12 deficiency It can cause lactic acidosis, especially in patients with renal dysfunction, and it can also cause GI disturbance. So GI disturbance, anyway, you will write in any question. So the other things I will mention here. It is known to cause vitamin B12 deficiency, and it is also known to cause lactic acidosis, especially in patients with kidney disease. So that's why dose reduction or avoiding the metformin may be required in patients with advanced kidney diseases. Okay. And today metformin is considered as the drug of choice for type 2 diabetes mellitus. For any patient with type 2 diabetes mellitus, until and unless there is a contraindication, we always give metformin. Okay. The second class of drugs we have is sulfonylureas. Now, how are they going to work? They are insulin secretagogues. They are insulin secretagogues. What do I mean by that? They stimulate the insulin secretion. A champion, if the patient is having renal dysfunction, depending on the degree of renal dysfunction, the lower the GFR, higher is the risk. And even a short-term exposure may be adequate if the patient is having very low GFR. So it's not just about the duration, it's about the kidney's function, ability to eliminate the end products. If kidneys are dysfunctional, quickly patient can get into the lactic acidosis. These are insulin secretagogues. What do I mean by that? They stimulate the pancreatic beta cells to secrete insulin. Examples what we can quote? Examples we have glimepiride, right? Then we have gliclazide. These are all sulfonylureas. Okay. Now, what advantages sulfonylureas bring? The advantages is that they are highly effective. Metformin can lower your HbA1c by around 1% or 0.8%, not like 2-3%. But sulfonylureas can decrease your HbA1c significantly. So their advantages, they are potent. They are potent. But otherwise, they have plenty of disadvantages or side effects. So what are the side effects? There is high risk of hypoglycemia. Why hypoglycemia? Because they stimulate the insulin production, and insulin is antagonistic to glucagon. So as long as insulin is high, it will keep the blood glucose level dropping, but your glucagon will not be able to easily counter it because the insulin antagonizes the glucagon. So like on one hand, you're taking away your defense against hypoglycemia. On the other hand, high doses, you're pushing towards hypoglycemia. So hypoglycemia risk is very real in sulfonylureas. Second side effect is it causes weight gain. Sulfonylureas cause weight gain. Why? Because how insulin works, insulin takes the blood from your glucose from your blood and pushes it into the cells, right? Cells, if they can use it, they will use it, or if it is excess, they will convert it into fat. All unused calories get converted into fat, to some extent glycogen. So now if I start putting more and more glucose to the cells, and if they are not able to use it, they will all convert it into glycogen and fat. So that is how we tend to gain weight. Any drug, including insulin, which works by increasing the insulin, causes the weight gain, right? Which is a serious side effect for many patients of diabetes mellitus. Okay. So today sulfonylureas are not the preferred class of drugs. But they had one more advantage is they are potent and they are cheap. So in India, we still continue to use because they are very cheap compared to modern drugs that we have like SGLT2 inhibitors or GLP-1 analogues. Good evening, Shiv. Good evening. Okay, so the next class of drugs we have is Thiazolidinediones. They are PPAR gamma activators. By activating PPAR gamma, they also reduce insulin resistance. By doing so, they also decrease insulin resistance. So they also do not cause, any drug that decreases insulin resistance does not cause hypoglycemia. What examples we can quote for the thiazolidinediones? I have drugs like pioglitazone, rosiglitazone. These are examples. So they have advantages similar to metformin. Though they do not have the anti-aging properties, they have advantages similar to metformin. What are the advantages? They are weight neutral. Okay, I wouldn't perfectly call them as weight neutral because some people may gain weight because of water retention. Okay, I'll come to that. But they also do not cause hypoglycemia. They do not cause hypoglycemia. Disadvantages. Disadvantages is they can cause edema, and through edema they can also cause weight gain. Of course, they're not increasing your body fat content, but because they are known to cause water retention, they can cause edema. And then they have one more advantage. The thiazolidinediones are effective in reversing the fatty liver. So if patient is having fatty liver, to some extent it responds to thiazolidinediones. Okay. Next we have DPP4 inhibitors. So in the body we have compounds called as incretins. A classical example of that is GLP-1. Okay, so GLP-1 facilitates the insulin production and inhibits the glucagon release based on your blood glucose levels. And if required, it can also facilitate the glucagon release and inhibit insulin release depending on our blood glucose levels. The added advantage of GLP-1 analog GLP-1 is that it can also suppress the appetite. As we start building the blood glucose level, it suppresses the appetite. So GLP-1 is a drug that is being explored. GLP-1 analogs are the drugs that are being explored for weight loss. And this GLP-1 once naturally produced in the body. So basically what GLP-1 is doing is glucagon like peptide 1, it can inhibit glucagon and stimulate insulin release whenever the blood glucose level increases. And whenever blood glucose level increases, it also inhibits appetite. It suppresses appetite. So the net result is that you eat less, you produce more insulin, and your blood glucose level gets better control. And because you're eating less, you also tend to lose weight. So if I'm using insulin to get the things done, I tend to gain weight, but here I'm losing weight. Now this GLP-1, I want more and more activity of it in my patient, but unfortunately what happens, an enzyme called dipeptidyl peptidase 4 degrades that into inactive peptide. It degrades into inactive peptide. So if I block this DPP4, then I can make the naturally produced GLP-1 in the body to act for a longer period. So that's why we came out with a class of drugs called as DPP4 inhibitors. The example, can anybody quote me an example for a DPP4 inhibitor? Yes, they all end with gliptins like sitagliptin, vildagliptin, vildagliptin. These are DPP4 inhibitors. So what are the advantages? Same advantages as metformin. They also do not cause hypoglycemia, no hypoglycemia, and they are also weight neutral. They are weight neutral. What are the disadvantages? The disadvantages is they are relatively low potency. In the sense, I cannot only depend on gliptins to treat diabetes for most patients. I would require metformin and it can only be used as an add-on. Or I may be treating them with sulfonylureas. I will use these as add-ons. I can rely on sulfonylureas alone to treat diabetes for a very long period of time before I need insulin. But DPP4 inhibitors alone may not be able to do a good job. It's not required. So if you are going ahead with GLP-1 analogs, right? GLP-1 analogs are very potent. That's why I mentioned here the low potency, because though it seems like we are trying to trap the same mechanism of action, I don't get good results with DPP4 inhibitors. I don't get to see weight loss. I at max say it is weight neutral because of the low potency. But if I use GLP-1 analogs, they are more potent than naturally produced GLP-1. So they can cause weight loss and all. So if I'm giving GLP-1 analogs, there is no point in giving the DPP4 inhibitors. Okay. So examples for GLP-1 analogs. Examples for GLP-1 analogs are liraglutide. So Chandan Patra, metformin, along with that we can consider the DPP4 inhibitors because they are not very potent, unlikely to cause hypoglycemia, weight neutral, don't cause weight gain. So they are quite safe. So again, low potency drugs make the initial drugs, right? The more potency drugs are usually kept as reserve drugs. Okay. Liraglutide and semaglutide. Semaglutide. So what are their advantages? The most important advantage, apart from good glycemic control, being highly potent, is that they also do not cause hypoglycemia, because their action is dependent on blood glucose level. So they will stimulate insulin and inhibit glucagon only when blood glucose level is high. Blood glucose level is low, the GLP-1 is silent. So you will not have glucagon suppression, so body will counter it and we will not get into hypoglycemia. So there is no hypoglycemia, and they cause significant weight loss. So currently the GLP-1 analogs are preferred agents for the pharmacological treatment of obesity. We have other drugs like bupropion, mephenteramine, phentermine, topiramate, the long list of pharmacological medications, orlistat. But the preferred agent for the pharmacological treatment of obesity right now is GLP-1 analogs like liraglutide or semaglutide. Okay, so disadvantage wise, there were some concerns, though debunked mostly. There were some concerns about the cancer risk. There were few initial studies which showed that GLP-1 analogs increase the risk of certain malignancies, but recent studies do not agree. So you can just put a question mark saying there is query cancer risk. And the second disadvantage is the cost. They are damn expensive, beyond the reach of most average Indians. So that's why they are not kicking off in the pharmacological management of diabetes yet. Okay. So what is the best thing that I can offer from the modern drugs to average Indian patients? It is the SGLT2 inhibitors. How do they work? They inhibit reabsorption of glucose at proximal convoluted tubule. E Chandan Patra, right? But again, as I've told you, the recent studies have not strongly suggested the risk of cancer. Only the initial studies had shown so. So there's a concern. Maybe after a few years, we'll have much more clarity whether there's significant increase in the cancer risk or it was because of some co-founding factors. Okay. So SGLT2 inhibitors, they normally how kidneys work. They first filter all small molecular weight substances. Then जो भी जरूरी है, we reabsorb. That reabsorption of glucose, almost 100% of the glucose happens at PCT with the help of SGLT2. And if I block it, I will not be able to reabsorb a reasonable amount of it. I will lose it in the urine. So they also come with advantages. We forgot to mention the most important advantage of GLP-1 analogs. GLP-1 analogs are known to decrease cardiovascular mortality in what all patients? In patients with heart failure, in patients with ischemic heart disease, and in patients with chronic kidney disease. So anyone who is having CKD, IHD or heart failure, if I give them GLP-1 analogs, their risk of death comes down. And I get the same benefit with the SGLT2 inhibitors also. So advantages wise, the SGLT2 inhibitors, they can also cause weight loss. They don't cause hypoglycemia. They can also cause weight loss because I'm losing on an average 70 grams of glucose per day in urine, and 70 grams of glucose is equal to 280 calories, right? 1 gram of carbohydrate is 4 calories. So this makes me lose 280 calories per day, which is equivalent to swimming for 45 minutes or more. So that much of exercise passively this drug is doing for me. So it helps me to lose weight. Okay. And then this also decreases cardiovascular mortality. I will come to that. Decreases cardiovascular mortality in patients with heart failure, in patients with ischemic heart disease, and in patients with CKD. What are the disadvantages? Because I'm excreting glucose in the urine, right? I become vulnerable for urinary tract infections, especially females, fungal as well as bacterial UTIs. So there is increased risk of urinary tract infections. Urinary tract infections. Okay. So Shiv, there are two strategies that are followed. In India, mostly we have seen fungal urinary tract infections when we started them on the SGLT2 inhibitors. So giving antifungals and continuing UTI works well. But if it is bacterial, stopping for a short while, treating the urinary tract infection, and then reintroducing is the strategy that we follow. And the prevention is possible even when patient is on the SGLT2 inhibitors. Prevention is reasonably possible if you maintain the hydration, good intake of fluids, and good genital hygiene. If there is someone who is getting recurrent urinary tract infections on the SGLT2 inhibitors, it is considered worthwhile to continue SGLT2 inhibitors and give them some antibiotic prophylaxis. Because even if I do not give SGLT2 inhibitors, many diabetics will have recurrent urinary tract infections. And how do we manage them? By giving them antibiotic prophylaxis like the nitrofurantoin. Okay. So there were also some concern about increased fracture risk in some studies. Now no longer they are considered as a concern. So only disadvantage that I want you to mention is UTI. There is one more. There is something called as normoglycemic, or you can say euglycemic ketosis. Now what do I mean by that? DKA. What is DKA? Diabetic ketoacidosis. Why that happens? Because in the absence of insulin, our cells are not able to metabolize glucose. So they are now switching to free fatty acids as the primary reserve for energy or calories. And from the free fatty energy metabolism, there will be production of ketone bodies. Ketone bodies are acidic in nature, so blood pH becomes acidic. That's why we're going to call it as ketoacidosis. In such cases, very high levels of blood glucose is getting excreted in urine as the glucosuria. And the glucose being osmotically active, we will also lose a lot of water. So I tend to get severely dehydrated. So on one hand, ketone body production, acidosis, glucosuria leading to dehydration. That is our diabetic ketoacidosis. Now, if I'm giving SGLT2 inhibitors, I don't have ketone body production. Okay, I may not have ketone body production to start with, but I start losing a lot of glucose in urine. So I start developing the features very similar to the diabetic ketoacidosis, where patient will have dehydration, hypotension. Because of the dehydration, I will have the similar features here. But when I check the blood glucose level, it will not be high. DKA is seen when blood glucose level is more than 250. Here, even with the blood glucose level less than 250, I start seeing some signs and symptoms of DKA. We will call it as euglycemic ketosis. Is it preventable? Yes. Of course, preventable. How preventable? Make sure patient is well hydrated so that the signs and symptoms do not emerge. Okay. Next is insulins. Insulins are not preferred agents for treatment of type 2 diabetes today. 15-20 years back, doctors used to struggle, right? Doctors used to always try to push people away from the sulfonylureas and metformin and go into insulin, because insulin is how body controls blood glucose level, right? But over the last 10-15 years, we have understood that insulin is not the way to go forward. Why? Because if I give insulin, you have insulin resistance. We're talking about type 2 diabetes. If I give insulin, I need larger doses of insulin than physiologically produced in body to overcome that resistance. So the more and more insulin I give, there will be also development of more and more resistance. So with progression of time, the insulin need goes on increasing. And how insulin is going to work? Take the blood glucose level, put it into tissues. So we are making the person gain more fat and weight. So the metabolic derangements that diabetes bring, half of them we are not solving by making them gain more weight, right? Only the hyperglycemic symptoms, the polyuria, polyphagia, they're being taken care by giving insulin. So that is why if you ask me, sir, what is the best class of drugs that I can give to patients with diabetes mellitus? Today I would say, if they can afford, GLP-1 analogues are the best drugs. If they cannot afford, next best class of drugs are SGLT2 inhibitors. Of course, for all patients, Metformin is anyway there. Everybody affords it because it comes in paisas or just few rupees, 2 rupees, 3 rupees, not more than that. These drugs are used selectively. Thiazolidinediones are almost going out of practice because they cause a lot of edema and weight gain, which makes patients feel uncomfortable. Sulfonylureas only right now used mostly in the government setups where these modern, more effective and relatively more safer drugs are not available. Okay. Now coming to insulins, those patients where I'm not able to control despite use of good medications. In them, we have to switch to insulins, and we all know that insulins can be divided into short acting and long acting. I can further divide into ultra short acting, and long acting. We will just keep it simple. We will classify them as short acting and long acting. Long acting can also be called as basal insulins because their job is to mimic the basal insulin production in the body. So examples for long acting we have is Can anybody give me example? The classical example is glargine. Then we have NPH. Short acting, we have example Actrapid. Yeah, Degludec. Degludec is in fact a very beautiful insulin, because when we are using basal insulin, we want that insulin not to have a peak. Means once it is given, it should achieve a decent blood level without having a peak, because its job is to mimic the basal production of insulin in the body. On the other hand, the short acting is supposed to have a peak and then come down. But of course, when it is naturally produced in the body, there is constant production and release. Here we are giving one dose at once a day or twice a day. So of course there will be a small peak after the administration, and then the peak will come down. But Degludec is almost flat profile, relatively peakless, but it is costly. So in India, mostly we end up using glargine or NPH. Okay. Yeah. So we don't have to detailed classification of insulin is not required in a medicine question, but yeah, if they are asking you to elaborate on the detailed classification, you can definitely classify them as ultra short acting, and long acting. You can also write about the duration of action, the peak levels, and the duration of action of individual insulins. If it is a 10-mark question, by the time we have reached here, we would have already spent 20-25 minutes in writing, so no need to elaborate more, because the question further goes on complications of diabetes. Okay, so in the complications, we will divide them into acute and chronic. So in acute complications, there are 3 acute complications that you have to write. One, hypoglycemia. Remember, 99% of the patients of hypoglycemia that you are going to see in your life are diabetics. So only 1% may be having insulinoma or starvation or cancer or some other causes. Otherwise, majority of the patients of hypoglycemia that you are going to see is because of diabetes. Why that happens? Because especially it is more common in patients with sulfonylureas and the insulins, because sometimes they take sulfonylureas or insulin and then do not take appropriate carbohydrate intake, so they can go into hypoglycemia. Okay. Second one is diabetic ketoacidosis, which is typically more common in type 1 diabetes mellitus. And then third one is called as hyperosmolar hyperglycemic state. Hyperosmolar hyperglycemic state. Hyperglycemic state, or HHS, which is typically more common in type 2 diabetes mellitus. That does not mean that DKA doesn't happen in type 2 or HHS. HHS usually doesn't happen in type 1, but DKA can happen in type 2. Especially Indian population is prone to develop diabetic ketoacidosis than the hyperosmolar hyperketotic hyperglycemic state. Okay. What is the difference between the two? In diabetic ketoacidosis, there is absolute insulin deficiency, right? Remember, in type 1, there is absolute insulin deficiency. So the tissues are not able to use glucose as a metabolic reserve. There is total shift towards free fatty acids as a source of metabolism. And when free fatty acids are metabolized, there is generation of ketone bodies. Okay. On the other hand, in type 2 diabetes mellitus, there is no absolute insulin deficiency. Body is producing some amount of insulin, but it is not able to work at the level of receptors. So there is some amount of insulin production. So we are not totally dependent on the free fatty acids as the source for calories. So we are still using some amount of glucose. So what problem happens here? We do not generate ketone bodies too much, because we are still utilizing glucose as the source for calories. The problem is, because your insulin is not sufficient enough, slowly blood glucose level starts rising. And as the blood glucose levels start rising, the serum osmolality starts increasing. We will start having severe osmotic polyuria. And because of polyuria, we will end up becoming dehydrated and we present with dehydration related symptoms. So in DKA, we have dehydration because of polyuria, plus we also have ketone body production. In HHS, we do not have ketone body production, only dehydration. So now tell me, which one is more serious? प्रकाश लेने की कोशिश करता हूँ, तो दोनों में कौन सा ज़्यादा सीरियस है, HHS और DKA? The answer is, you may be thinking that in hyperosmolar hyperglycemic state में तो ketone body production नहीं है, so it will be less serious and DKA will be more serious, but that is wrong. DKA is less serious and HHS is more serious. Why? Because DKA, once the ketone body production starts, that ketosis leads to various symptoms, right, including muscle cramps, the ketotic breath, then ketotic breathing, that brings the patient to hospital. तो ये लोग hospital बहुत पहले पहुंच जाते हैं. The DKA patients present early because of the ketotic symptoms. And in HHS में ketotic symptoms नहीं है, तो they present late. So by the time they present, their blood glucose level will be much higher. So when you look at the blood glucose level at the time of presentation, DKA is 250 plus. On the HHS, it is usually 600 milligrams per deciliter or higher. 600 milligrams per deciliter or higher. Okay. And in such cases, the degree of dehydration that I am going to get, because higher the blood glucose level, I would have more profound polyuria and I will be more dehydrated. So these patients are more severely dehydrated or more dehydrated compared to DKA, compared to diabetic ketoacidosis. So exam में बस इतना ही लिखना है. The major difference between the two is in DKA, absolute insulin deficiency that has pushed us to using free fatty acids as the only source of energy, and thus we are generating ketone bodies. These ketone bodies make me come to the hospital early. I will not wait for my blood glucose level to go in thousands. Before that only, it will take me to the hospital. But यहाँ पे, because ketone bodies are not there, they present late, and because they are presenting late, by the time they will be severely dehydrated. So DKA patients will have approximately 6 to 8 liters of fluid deficit at the time of presentation. But these patients, they will have more than 9 liters of fluid deficit at the time of presentation. Means they would have already lost more than 9 liters of body water when they come to hospital. These patients present early, so they would have lost less than 9 liters of body. So that is why DKA is less serious, HHS is more serious. So HHS carries higher mortality than diabetic ketoacidosis. Okay. So that's about our acute complications. Now what chronic complications we can expect? The chronic complications of diabetes will be classified into two groups. We will classify them as microvascular and macrovascular. Macrovascular. So what comes under macrovascular complications? The ischemic heart disease, then stroke or cerebrovascular accident, and then peripheral vascular disease. These are all macrovascular complications. What are the microvascular complications? Micro हम बहुत आसानी से याद रख सकते हैं. All you have to remember is pathies. Anything that ends with a pathy. That is neuropathy, nephropathy, retinopathy. These are microvascular. So microvascular, we will have diabetic retinopathy, diabetic nephropathy. When you write about diabetic nephropathy, just mention few extra points just to please the examiner. Extra points क्या लिखना है? Diabetic nephropathy is the most common cause for CKD. Means more than 2/3 of the patients who are on dialysis today, they have reached that stage because of the uncontrolled long-standing diabetes. So diabetic nephropathy is the most common cause for chronic kidney disease. Okay. Then we have diabetic neuropathy. Diabetic neuropathy means there is nerve damage. Here we have to mention most commonly what pattern we get. We get distal sensory motor. So Chandan Patra, if bicarbonate loading is not advisable for any patient with acidosis until and unless the acidosis is very severe. Okay, so there are two schools of thoughts, different guidelines. Some guidelines recommend when it is less than 7.1, we should give bicarbonate. At the very physiology level, less than 6.9 is not suitable for the cellular metabolism. So less than 6.9 is not acceptable at all. So when it is less than 6.9, definitely we need to give 6.9 to 7.1. Some guidelines recommend we can give. More than 7.1, we don't need to give. All we have to do is correct the abnormality. The acidosis will be sorted, right? So give insulin, give fluids, right? Make sure that hydration is taken care of and the hyperglycemia is appropriately controlled. This acidosis will resolve on its own. But if it is less than 6.9, I would say you have to give because it's not suitable for cellular metabolism. It pushes to hypotension, shock, and death. So for temporarily getting the pH corrected, give it, but still the mainstay of treatment for correction of acidosis is correcting hyperglycemia and dehydration. Okay, diabetic neuropathy most commonly presents a distal sensory motor polyneuropathy, which can be described as distal weakness. Patient will have distal weakness and distal sensory loss, which can be described as glove and stocking distribution, of sensory loss and the weakness. So mainly these patients will have weakness of small muscles of the hand and feet and loss of sensations in the hand and feet, right? So that's why it's called as glove and stocking distribution. Okay, so that's about the complications of diabetes mellitus. So we'll move to the next question. The next question is going to be on the thyroid. Write a short note on thyroid disorders. Explain mixed edema coma and thyroid storm. So these thyroid storm and the mixed edema coma, these are two acute emergencies related to thyroid gland. Otherwise, when they say explain thyroid disorders, we are supposed to explain three things. First one is hypothyroidism. Second one is thyrotoxicosis. Third one is thyroid tumors. Tumors we will leave it to surgery. We will address hypo and hyperthyroidism, right? So we'll start with the hypothyroidism. So what is hypothyroidism? Hypothyroidism refers to decreased T3 and or T4, decreased T3 and T4, leading to what? This decreased T3 and T4 will lead to? Leading to hypometabolic state. If T3 and T4 is low but patient's metabolism is fine, there are no symptoms, we will call it a subclinical hypothyroidism. When we say overt hypothyroidism, low T3 and T4 has resulted in slowing down the metabolism and symptoms arising out of it, right? So remember, the thyroid hormone T3, T4 are the major determinants of the metabolic rate. What is metabolic rate? The rate at which we burn glucose or calories, right? So higher is the T3 and T4, we will burn more and more glucose. And when we burn more and more glucose, in the process of calorie utilization, we generate a lot of heat, right? So indirectly, it is responsible for the body heat generation. Okay. Now, what can cause hypothyroidism? Okay, so we all know that our hypothalamus produces a hormone called as TRH. This thyrotropin releasing hormone comes and stimulates the pituitary gland to produce another hormone called as TSH. This TSH comes and stimulates the thyroid gland to produce T3 and T4, right? T3 and T4. Now, when the T3 and T4 is low, we are going to call it as hypothyroidism. Okay. Now, it can be low because of the problem in the thyroid gland. In that case, we will call it as primary hypothyroidism. Why are we using the term primary? Because the main problem कहाँ पे? जिस gland से hormones आना है, वहीं पे problem है. Right? Whichever gland is supposed to produce this hormone, that gland itself is dysfunctional. Then we will call it as primary. But if the next higher regulatory level, there is a problem. Like pituitary gland is not producing TSH. So TSH is low. Because of that, T3, T4 is low. We will call it as secondary hypothyroidism. And if thyroid is also fine, pituitary is also fine, but your thyroid hormone is low because of hypothalamic dysfunction. TRH production is decreased, so TSH is decreased as a result, and then T3, T4 is decreased, then we will call it as tertiary. Okay. Tertiary is extremely rare, so in clinical practice, we primarily focus on secondary and primary. So we will divide the causes for hypothyroidism into primary and secondary. Primary and secondary. Okay. Now primary means defect in thyroid gland, right? Primary is always defect in the main gland which is supposed to produce that hormone. So defect in thyroid gland, we are going to call it as primary. So if there is defective TSH production from pituitary, right, by anterior pituitary, then I'm going to call it as secondary. So what examples I can quote as causes for the primary? Okay, there can be congenital malformations and all. Right now we don't need to write. We will write the common causes. What are the common causes for primary hypothyroidism? The most common cause is autoimmune, which is Hashimoto's thyroiditis. Hashimoto's thyroiditis, which is autoimmune. And the second one is iodine deficiency. Iodine deficiency. Among these, this is the most common cause for hypothyroidism. This is the most common cause. And what antibody we are generally getting in Hashimoto's thyroiditis? We will have anti-thyroid peroxidase or anti-TPO antibodies. Anti-TPO antibodies. Okay. Secondary, what causes I should mention? The secondary can be pituitary dysfunction due to radiation or compression by other pituitary tumors. Like let us say I have a growth hormone producing pituitary tumor. There is a acromegaly. This tumor may compress the thyroid producing cells, thyroid hormone producing the TSH producing cells, and the TSH production may be down. Many times when we have tumors, pituitary tumors, we try to give radiation, we end up destroying TSH producing cells. So those are secondary causes. Overall, what is more common? Of course, overall it is the primary which is more common. Among them, Hashimoto's thyroiditis is more common. Once upon a time, iodine deficiency used to be an important cause for hypothyroidism, especially people living in the mountains where the soil is low in iodine. But it's no longer a concern since most countries, governments have made fortification of salt with iodine as a standard requirement. So it's no longer a major deal. It's still Hashimoto's thyroiditis, which is the most common cause for hypothyroidism. Now, with what clinical features these patients will present? Of course, there is decrease, right? First thing we have to remember when we talk about hypothyroidism is decreased metabolic rate. There is decreased metabolic rate. So when someone has decreased metabolic rate, they are burning calories less and less. So what will happen to their weight? So they tend to gain weight. So these people will have weight gain. Okay. Now if my metabolic rate is low, my cells are not able to burn glucose rapidly, right? So in that case, the rate at which my cells can generate ATP is less. So my ability of my muscles and cells to function is reduced. So I can have fatigue. Fatigue and weight gain are the most common symptoms that bring these patients to hospital. Okay. What is the third symptom I would expect? If metabolic rate is low, the rate at which I generate heat is low, right? So if I'm exposed to cold, let us say that I have gone to Himalayas in a very cold environment. Now the external cold will try to cool my body. So now my body has to generate more heat to ensure that the normal metabolic functions of the cells are taken care. So how do I generate that? By increasing the metabolic rate. How do I increase? By burning more glucose, right? For that, again, I need help of thyroid hormones. So if I have deficiency, I will not be able to elevate the body heat whenever I'm exposed to cold. So we will have cold intolerance. Cold intolerance. Okay. Then patients can have hair loss because the cell turnover is becoming slower because of the slower metabolic rate. So patients can have hair loss. Then females can have menorrhagia. Then people can have non-pitting edema, non-pitting pedal edema. Now, why is it non-pitting? Because it is not because of the fluid and sodium retention, but because it is due to accumulation of glycosaminoglycans or GAGs. GAGs are hygroscopic substances. They hold a lot of water. So it is not the salt water retention, but water holding of the tissues is increased because of accumulation of glycosaminoglycans. And when I press, I cannot displace glycosaminoglycans from the tissues. So I cannot also displace the water molecules which are bound to glycosaminoglycans. So I will not be able to create a pit. So we'll have non-pitting edema. Okay. So in terms of heart, we can have bradycardia. I may even get hypertension. When I get hypertension, it is the diastolic hypertension. So systolic BP is generally normal. SBP does not increase, but diastolic BP can be increased. So we will have narrow pulse pressure. Okay. Then what else hypothyroidism can cause? Hypothyroidism can cause delayed relaxation of muscles. So when muscles contract, the relaxation is very delayed. Like if I contract a muscle, the relaxation will be slow. And this we can demonstrate on the ankle jerk, right? Hit, the calf muscle contracts, but then it relaxes very slowly. So there's a name given to this sign. What is that sign called as? The sign is called as Voltman's sign. Voltman sign. What is Voltman sign? Delayed relaxation of ankle jerk. This can also be written as hung up ankle jerk. Hung up ankle jerk means contracts hands there, it's not relaxing quickly. That is Voltman sign. Okay, what else it can cause us? Because there is slowdown of the metabolism, it can also lead to anemia. What kind of anemia? Usually normocytic, normochromic, normocytic, normochromic anemia. And as worst part, it can also cause what we call as myxedema coma. Myxedema coma is a complication where the severe hypometabolism has resulted in slowing down cardiac functions and brain functions. The patient becomes comatose, and the cardiac function slowing results in hypotension. And another thing, another hypo that is happening here is hypothermia, because we are not able to generate sufficient heat. So myxedema coma is characterized by coma plus hypotension and hypothermia plus hypothermia. So these are all clinical features we can write in hypothyroidism. As an examiner, what I will be looking for? You must mention weight gain, fatigue, cold intolerance, and menorrhagia, because these are the relatively more common complaints, and these are the complaints that patients bring to hospital. Okay. Bradycardia and other findings that we discussed is something that we elicit by observation or examination. Okay, so now if I'm suspecting hypothyroidism, how will I make a diagnosis? So there are two things here. One, diagnosing the underlying cause, and establishing the diagnosis of hypothyroidism. Okay, so what investigations I will require? I will require T3, T4, ideally free T3, T4, and the TSH, right? So if I have a patient whose free T3, T4 are low and TSH is high, what does that indicate? And if I have a patient who has free T3, free T4, but TSH is low, okay, with clinical features. And I have another patient with free T3, T4 which are low, free T3, T4 are low, TSH is high, but no clinical features. So what will be my diagnostic interpretation in those cases? No clinical features. So the first case, what do I understand from the first case? There is decreased production of T3, T4, but TSH is high. So what does that mean? Your pituitary gland is functioning fine, but your thyroid gland is not. And just to compensate for thyroid dysfunction, pituitary gland is trying to produce more TSH. So the first scenario is primary hyperthyroidism, right? It is primary hypothyroidism, primary hypothyroidism. In the second scenario, your pituitary gland is not working. That's why your thyroid gland is not working. So I will call it as secondary hypothyroidism. Secondary hypothyroidism. What about the third case? In the third case, T3, T4 are low, TSH is high, but patient does not have any symptoms. So we will call it as subclinical. We will call it as subclinical hypothyroidism. So we'll call it as clinical hypothyroidism when some symptoms are there, like patient is at least having fatigue, right? Like we discussed, fatigue, some degree of weight gain, some degree of menorrhagia or cold intolerance, absolutely no symptoms, then we will call it as subclinical hypothyroidism. Okay. So that is the initial diagnosis, right? So what other investigations I would require for evaluation? The commonly performed investigations for further evaluation to know the underlying causes. One, anti-thyroid peroxidase antibodies. So if it is positive in patients with Hashimoto's, they are positive in Hashimoto's. In subclinical, free T3T4 need not be normal. So the term subclinical comes into picture only for one reason, that they do not have the symptoms. Once they start getting the symptoms, we will call it as clinical. So if free T3T4 is normal, it is normal. Total T3T4 does not matter. Why it does not matter? Because total T3T4 depends on T3 and T4, which is bound to albumin and thyroid binding globulin. So normally, okay, so when I produce T3 and T4, right, some amount of it gets bound to albumin, some amount of it gets bound to thyroid binding globulin, and some of it circulates in free form. So the one it is circulating in free form is biologically active. It is the bioactive thyroid hormone. Okay. This is bioinactive. It is primarily our body's mechanism to store, so that when required, we will release it from the TBG. So it is bioinactive. And the one that is bound to albumin is also biologically inactive, but it can be quickly, easily released, right? So it is, if required, quickly released, again, if required, from the albumin. So collectively, the bioactive and the albumin bound is called as bioavailable. Means if I need, albumin bound is also available to me, and free T3, T4 are anyway, they are biologically inactive, they are circulating and they are doing the job. Now, conditions where this albumin levels can increase or decrease, right? If albumin level increases, they can bind more T3, T4. So your total T3, T4, like when I look at total, T3, T4 will be high. Conditions where albumin decreases, your total T3, T4 will decrease because less is bound to the albumin. So it does not matter at all. So if I have a patient with total T3, T4 low or high, I have to invariably do free T3, T4 to understand whether patient is in hypo or hyperthyroidism. I cannot judge based on the total. So that is why when you look at the books, they only recommend doing free, because whether hypo is there or hyper, we can only get to know by doing free. And if free is low, that means there is hypothyroidism. If free is high, there is hyper. Whether it is clinically overt or subclinical, we will decide based on whether clinical symptoms are there or not. Okay. Okay. So again, if it is NVK, if it is a female patient that you're talking about, I forgot to mention, even hypothyroidism causes hypertriglyceridemia. So that can be one of the cause. So do get it evaluated. But if thyroid issues are not there, first step for any degree of dyslipidemia is to, until and unless the triglyceride levels is more than 1000, where there is a risk of acute pancreatitis, first step is to restrict the saturated fats from the diet. Ask the patient to lose some weight, like 10% of the body weight over 6 months, and to recheck the triglyceride profile or the lipid profile after 3 months and see if they are coming back towards the normal range. If dietary modifications and weight loss is helping, well and good. If not, we can try to treat it. In terms of treatment, we have statins and the fibrates. For triglycerides, statins alone may not be adequate, especially if it is on the quite higher side. So you might have to give a combination of statins plus fibrates. Okay, so anti-TPO antibodies for Hashimoto's. Okay, and CT or MRI, of course, MRI is better, of MRI pituitary gland for secondary causes, right? Pituitary for secondary causes. Okay. Now, once I've investigated, I got to know what it is. Now, how will I management of hypothyroidism? Of course, the only way I can get their metabolism boosted is to give thyroid hormone replacement. The form of replacement agent that we are using is levothyroxine. Levothyroxine. We need to give dose. How much dose I should give? Let us say that thyroid gland is totally dysfunctional, not producing any levothyroxine at all, I mean any T3 T4 at all. In such cases, the body's basal requirement is 1.5 to 1.6 micrograms per kg body weight. So you can start around that point, and then we can monitor regularly to understand whether I need to escalate or decrease the dose, because I don't know how much is the native production in the patient's body, right? But otherwise the basal requirement is 1.6 micrograms per kg. So we'll start with 1.6 micrograms per kg. So in clinical practice, we roughly start with 1.5, easy to mentally calculate, because the levothyroxine is available in doses of 50, 75, right? Then 82.5, 100, 112.5, 125, 150, 175, 200. These are the available dosage forms. So what we can do is, like, if I'm dealing with a 50 kg person and if I want to give 1.5, it will be like 50 into 1.5, that is 75. So I will start with 75. If I'm dealing with a 100 kg individual, 100 into 1.5, 150 micrograms. So I will start with 150 micrograms. After that, like 6 weeks later, we will reassess the patient's TSH. We want to keep the TSH within the mid range of the normal. If it is there, then the dose is appropriate. If not, then we will keep adjusting the dose up or down till we achieve the target TSH. Once the target TSH is achieved and maintained, then annually we can follow up. We don't need to follow up more frequently. Okay, that is the dose of the levothyroxine that we are giving. Target TSH is mid-third of normal range. Initial follow-up, usually 4 to 6 weeks intervals, till target TSH reached and maintained, and further follow annually. Okay, now coming to an important complication of hypothyroidism, that is mixed edema coma. Okay, so it is not possible for me to know whether the thyroid gland has some native production of T3, T4 happening, or it is totally dysfunctional. So that's why I say we are using 1.6 as a starting point, because we know that that is the basal requirement of an individual when the thyroid gland is not there. How do we know? Because we have done total thyroidectomy in many patients. We have totally knocked out thyroid gland, and in them it is the basic requirement. Their requirement will be met when we give them 1.6 micrograms per kg. So in hypothyroid patients, we start around that. So in 1/3 of the cases, it may be little and overkill. So they may not require that much. So when they come back for follow-up, the TSH will be suppressed. We will decrease the dose a little, and then they will do well. For some patients, that may not be adequate. The requirement may be slightly higher. So when they come back for follow-up, we would not have reached the target TSH yet. So in that case, we will escalate the dose. But 1.6, because we know that is the rough basal requirement, it gives us an anchor point around which we can base our initial dosing. But otherwise, I won't get to know whether the thyroid gland is totally dysfunctional. As long as there is some degree of T3, T4 in the blood, we know that there is some degree of action of the thyroid gland. Okay. Now, what is mixed edema coma? Mixed edema coma is a acute severe complication of hypothyroidism, acute severe complication of hypothyroidism. The patients usually present with, I have already discussed the features. If metabolic rate is very slow, right, very low, my cells are not able to burn the calories. We are not able to generate the ATPs required for their survival. And the major toll will be taken by which organs? The organs which need the maximum amount of energy or ATPs. That includes your cardiac myocytes, right? Your brain cells. So it can lead to delirium, and if not treated, may lead to coma. Second, with respect to cardiac dysfunction, it can lead to hypotension because your cardiac muscle is not able to contract efficiently. Third, Because you're not burning adequate glucose, you're not generating heat in the body, you can go into hypothermia. Hypothermia. Right, so these are the three major consequences. Apart from that, these patients may tend to develop cardiac tamponade. Though rare, we should be aware of. But at least for the exam, what you need to write: delirium, coma, hypotension, hypothermia. So if a patient presents like that, how will I manage? Management of mixed edema, coma. There are few things to consider here. First thing I have to manage is the patient's metabolic rate, right? I have to boost the metabolic rate. If I don't boost the metabolic rate, patient body will not be able to generate heat. It will not be able to come out of hypothermia. His cardiac myocytes will not be able to function well. His neurons will not be able to function well. So how do I boost the metabolic rate? By giving IV levothyroxine. IV levothyroxine. Dose is not important in the written exam, so don't worry about it. IV levothyroxine is to be given as the loading dose. Usually we give around 200 micrograms as the loading dose. And then what else I have to do? I might require inotropic. I forgot to mention one more. These patients can also develop profound hypoglycemia. So inotropic agents may be required. We will require dextrose infusion to maintain the blood glucose level. And last but not the least, how will I manage hypothermia, right? So hypothermia may be managed with active rewarming. If core body temperature is less than 30 degree Celsius. If it is more than 30 degrees Celsius, I don't need to actively manage hypothermia. Just give some external blankets and all, and primarily focus on giving the IV levothyroxine. Okay, so that's about our mixed edema coma. Okay, now we will go to the next part of the question. We have addressed hypothyroidism. We will talk about hyperthyroidism. Okay, now there are two terms to learn here: thyrotoxicosis and hyperthyroidism. So what is thyrotoxicosis and hyperthyroidism? Yeah, Chandan Patra. So when we have hypothyroidism, not just the mixed edema, hypothyroidism itself can cause the hyponatremia. So that is why whenever we make a diagnosis of euvolemic hyponatremia as SIADH, we have to rule out hypothyroidism and hypercortisolism. And most patients with mixed edema will invariably have a reasonable degree of hyponatremia. Okay. Now coming to thyrotoxicosis versus hyperthyroidism. What is the difference between the two terms? The term thyrotoxicosis is a broad term which refers to increased T3 or T4. That is thyrotoxicosis. Then what is hyperthyroidism? This increased T3 or T4 can happen because of various reasons. Either your thyroid gland is producing too much of it, or like let us say I had a hypothyroid patient. I gave her a prescription, and unfortunately instead of taking one pill, patient is taking 10 pills a day. So that extra thyroid hormone is coming from outside the body. Then also blood T3, T4 will be high. So any condition, regardless of the cause, if there is excess blood T3, T4, we will call it as thyrotoxicosis. But if that thyroid hormone is only coming from the thyroid gland, not from other sources, then only we will use the term hyperthyroidism, because here thyroid gland itself is hyperactive. So the causes for thyrotoxicosis can be divided into hyperthyroidism and other causes. Hyperthyroidism and other causes. So among the other causes, it can be exogenous levothyroxine treatment. Many patients with hypothyroidism, when we are treating, our dose calculation can sometimes go wrong. We may end up over treating. They can come back with thyrotoxicosis. When they come back with symptoms, all tremors and all, we don't call it as hyperthyroidism. We will only call it as thyrotoxicosis, because this excess thyroid hormone is coming from outside, not from the thyroid gland. Okay. What other causes I can quote? You might have heard of something called as hamburger thyrotoxicosis. What does that mean? In Chicago and some part of the states, they used to use the beef thyroid gland or animal thyroid gland in the burger patties, and because the thyroid gland will be rich in the stored thyroid hormone, when they eat it, they are consuming thyroid hormone, so it will go to the blood, increase the blood T3 T4 levels, and patients will start developing tremors and other symptoms of thyrotoxicosis. It was called as hamburger thyrotoxicosis. Okay. Then third is there is a condition called as struma overi. What is struma overi? It refers to ectopic thyroid gland. Means thyroid tissue is also there in the ovaries apart from thyroid gland. So those ectopic tissue is producing extra thyroid hormone. It is not coming from the thyroid gland directly. It is coming from ectopic thyroid tissue, which is located in the ovaries. And because it is not coming from the thyroid gland, I will not call it as hyperthyroidism. I will simply restrict to the term thyrotoxicosis. But when we say hyperthyroidism, there is increased thyroid gland activity. Thyroid gland activity. When it can happen? It can happen in various conditions. One, we can call it as primary hyperthyroidism, where the thyroid gland itself is overactive directly. And we can also call it a secondary, where the thyroid gland is being stimulated to become more active. When it becomes more active, when it is being stimulated, when we have TSH producing pituitary adenomas. TSH producing pituitary adenoma. So if there's a pituitary tumor, it secretes TSH, it will go and stimulate the thyroid gland. Thyroid gland will produce more T3 and T4. This T3 and T4 is coming from thyroid itself, so I have to call it as hyperthyroidism. Okay. Now sometimes the thyroid gland itself can become active. Most common cause being Graves' disease. Okay. Then we can have multinodular goiter, where multiple nodules are there and those nodules are independently hyperactive, or I can have a solitary active thyroid nodule. Right. So primary can be Graves' disease. Graves' disease is the most common cause for hyperthyroidism. I can have multinodular goiter, and I can also have active solitary thyroid nodule. Solitary thyroid nodule. So these are all primary causes for the hyperthyroidism. So thyrotoxicosis has hyperthyroidism and other causes. Among hyperthyroidism, we have primary and secondary. Now, all these patients will present with certain clinical features. What clinical features? Kind of opposite to what we discussed in hypothyroidism. So, these patients of hyperthyroidism tend to lose weight because there is increased metabolic rate. And increased metabolic rate means you're burning calories a lot. So, if you're not eating appropriately, you will lose weight. So, weight loss. Okay. Second, increased metabolic rate also comes with heat intolerance, because you already generate a lot of heat in the body, right? Heat intolerance. Then you can also develop fatigue. Why are you developing fatigue when your metabolic rate is high? Yes, initially when metabolic rate increases, you're burning a lot of calories, generating a lot of ATPs, so you feel active, energetic. Many hyperthyroid patients are restless, they are difficult, it is very difficult to make them sit in a place, they are loitering here and there. But as the disease progresses, right, the muscles which are hyperstimulated, slowly they start losing their glycogen reserve and the metabolic reserve, and they start becoming weak. So these patients can develop proximal myopathy. Proximal myopathy. Okay. What else we can see in a patient with hyperthyroidism? One thing we have to understand is that the T3, T4, while increasing the metabolic rate, they also activate the sympathetic nervous system. And when sympathetic nervous system is activated, what will happen to our heart rate? Heart rate will increase. So patients can have palpitations because of increased heart rate, or they can, on examination, we will notice that they have tachycardia. And this sympathetic overactivation also increases the risk of atrial fibrillation in patients with thyrotoxicosis. Atrial fibrillation. Okay. Then there can also be increased sweating, right? Or diaphoresis, increased sweating or diaphoresis. Okay. Then these patients tend to have diarrhea. The patients with hypothyroidism tend to have constipation. They tend to have constipation. Okay. Apart from this, the hyperthyroidism, particularly, especially the Graves' disease, can also be associated with what is called as ophthalmopathy, where patients will have Proptosis. What is the reason for proptosis? What is the reason for proptosis? NVK I am planning. I have asked for a schedule. So once I find a suitable date when other faculties are not taking class, we'll also cover it. What is the reason for proptosis? It is typically seen in Graves' disease. Not all thyrotoxicosis patients. Seen in Graves' disease. So there is accumulation of glycosaminoglycans in the retroorbital fat pad. So behind the orbit, there is little bit of fat. In them, there is accumulation of glycosaminoglycans. Glycosaminoglycans, being hygroscopic, they bind to more water molecules and push the eyeball forward. Okay. Now, if I treat the thyrotoxicosis, will Graves' ophthalmopathy improve? Will the Graves' ophthalmopathy improve? The answer is no. Why it will not improve? Yes, Chandan, absolutely. Why it will not improve? Just drop a comment why it will not improve. Then it will also cause what is called as Graves' dermopathy, which is nothing but pretibial mixed edema. Pretibial mixed edema. So these are the clinical features of thyrotoxicosis. Here the specific for the Graves' disease is the ophthalmopathy. Why ophthalmopathy does not improve? Because this accumulation of due to accumulation of glycosaminoglycans or GAGs in retroorbital fat pad is not because of the T3 T4. T3 T4 are not doing it. T3 T4 is responsible for the lid lag and stay loop because sympathetic activation. This is because in Graves' disease, right? I think we have not written a note on it. So remember, in Graves' disease, what is the main pathology? In Graves' disease, there is an antibody. It is an autoimmune disorder, right? So we have an antibody which is called as thyroid receptor antibody, or they are also called as thyroid stimulating immunoglobulins. Thyroid stimulating immunoglobulins. So basically what they do is on the thyroid gland, we have TSH receptors, right? We have TSH receptors. These traps or the thyroid stimulating immunoglobulins stimulate the TSH receptor. And if I stimulate the TSH receptors, the thyroid gland will start producing T3, T4, thinking that pituitary has sent TSH, right? So they are doing the job of TSH on the receptor. But these traps, right, they directly stimulate the fibroblasts, right? So they also stimulate fibroblasts too, and fibroblasts produce glycosaminoglycans. So if I reduce the thyroid gland activity by giving antithyroid drugs, T3, T4 will come down. But these traps are directly stimulating the fibroblasts. T3, T4 is not stimulating them. So GAG production will not come down. So your ophthalmopathy will not respond to antithyroid drugs. Clear? Okay. So now that I have suspected hyperthyroidism, I forgot to mention one more. This can also cause hypertension. When it causes hypertension, it is primarily causing increase in the systolic BP and relatively normal diastolic BP. So as a result of this, it causes what we call as wide pulse pressure. Wide pulse pressure. And this wide pulse pressure can lead to various other findings like the collapsing pulse or Corrigan's sign. The things that we see in aortic regurgitation can also be seen in patients with thyrotoxicosis. It is because of the wide pulse pressure. Okay. So when I have suspected a case as having hyperthyroidism, how will I confirm the diagnosis? So first step is to understand whether there is hyperthyroidism or thyrotoxicosis present or not. How will I confirm? Of course, by looking at T3 and T4. So I may have a patient with free T3 and T4 increased. That means there is thyrotoxicosis, and the patient's TSH is decreased. And I may also have another patient who has free T3 and T4 increased, but the TSH also appears to be increased. So in the first case, what is the story? Thyroid gland's production is increased. and appropriately there is suppression of the pituitary gland. So that means the problem is in the thyroid gland itself. So it is primary hyperthyroidism. It is primary hyperthyroidism, right? So what conditions I can think of? I can think of Graves or multinodular goiter, where the problem is in the thyroid gland. In the second scenario, T3, T4 is high, TSH is also high. So that means we are mostly having, because pituitary is producing too much TSH, your thyroid gland is responding appropriately with increased T3, T4. So in that case, we have secondary hyperthyroidism. So in that case, we are thinking of pituitary adenoma producing TSH. Clear? Okay. So once in the TFT I have understood whether it is primary or secondary, how will I investigate further? See, secondary is very easy, right? All I have to do is image the pituitary gland and find out tumor, whether it is there or not. Primary, I have to differentiate between Graves, multinodular goiter, and solitary active nodule. So for that, one investigation that can help me is radioactive iodine uptake. So what picture I will get? If it is Graves disease, there is uniform uptake, increased uptake of the radioactive iodine, because your whole thyroid gland is inflamed under the autoimmune attack, plus the antibodies are directly stimulating the thyroid gland, so thyroid gland activity is increased. Of course, the antibodies are not selectively choosing, I will only stimulate right thyroid gland, or I will only stimulate one small area of the thyroid gland. So there will be uniform increase in the tracer uptake. Uniform increased radioactive iodine uptake. Then it is suggestive of Graves disease. On the other hand, if I have patchy increase, then it is suggestive of multinodular goiter. So I do a radioactive iodine uptake scan, and what do I notice? There is only patchy increase, not uniform. So if there is patchy increased radioactive iodine uptake, it is suggestive of multinodular goiter. And if I see only one spot where there is increased uptake, then it is suggestive of solitary active nodule. Right. So single active spot of radioactive iodine uptake, it is suggestive of solitary toxic nodule. So that is how we will interpret the radioactive iodine. So that is particularly useful in understanding which type of primary hyperthyroidism I have, whether it is Graves, MNG, or the solitary toxic nodule. Many cases we are also helped by detection of the antibodies, that is thyroid receptor antibodies or thyroid stimulating immunoglobulins. So if the TRAbs are positive, what is it suggestive of? It is suggestive of Graves. So I may not unnecessarily do a radioactive iodine uptake study. If antibodies are positive, I would take it as Graves, because we know that Graves is the most common cause for hyperthyroidism. So if there is a hyperthyroid case, plus antibodies are also there, I'm done with the diagnosis. Only when I'm in doubt, I will do the radioactive iodine uptake scan, and the scan, if it is Graves, will show uniform uptake increase. If it is MNG, multiple nodules, multiple increased tracer uptake spots. Only single toxic nodule, single tracer uptake increase. Can we start anti-thyroid medications for exogenous? No, we don't need. See, why do we need to do anti-thyroid medications for exogenous? Stop the exogenous dose. Remember, the T3, T4 have a, like levothyroxine has a half-life of around 7 days. So if I stop giving the levothyroxine today to the patient, then by 7 days the blood levels would have dropped down by half. Right. So during this period, the thyrotoxic manifestations can be taken care by giving beta blockers. Remember, these patients, if exogenous administration is very high, that would have suppressed the TSH. So thyroid gland will not be producing much T3, T4. So I don't have to suppress the thyroid gland per se. All I have to do is stop the exogenous administration. Okay. So now we know how to make a diagnosis of patient presenting with thyrotoxicosis. Coming to the management, of course, that if cause is, as Chandan Patra was mentioning, if the cause is factitious or exogenous administration, just treat the underlying cause. So we'll restrict to the hyperthyroidism per se. How will I manage? I like Graves' disease or MNG or toxic solitary nodule. How will I manage? So I have surgery, radioactive iodine uptake, and pharmacological management as a choice. Pharmacological management is not considered as a definitive treatment because many patients we will be able to control the thyroid gland overactivity by giving drugs, but after withdrawal of the drugs, it bounces back. Okay, so definitive treatment is going to be either do radio iodine ablation or thyroidectomy, but current approach is that give antithyroid drugs for 12 to 18 months. At least some patients, the underlying immune process will resolve, and after that we don't need to continue antithyroid drugs. So you may be able to stop somewhere between 12 to 18 months of time. But those who continue to be in hyperthyroid state despite 18 months of antithyroid drugs, better to push them to surgery or radioiodine therapy. So in terms of drugs, we have antithyroid drugs, which includes 3 drugs: carbimazole, methimazole, and propylthiouracil. Methimazole and propylthiouracil. They have their own roles in the management of hyperthyroidism. Carbimazole and methimazole are the preferred agents, propylthiouracil in selected cases. Okay, so you can mention that these are preferred agents for most patients owing to their potency. Okay, the other advantage of carbimazole, methimazole, not the advantage, the side effects, right? We should mention some side effects of carbimazole, methimazole. One of the side effects is they can cause neutropenia, or you can write it as agranulocytosis. They can cause agranulocytosis, and monitoring for agranulocytosis is strongly recommended, and they are teratogenic. So when I say teratogenic, what problem they can cause? They are teratogenic. So what problem I am expecting them to cause? They can cause 2 teratogenic manifestations. One of them is aplasia cutis. So some part of the body, the skin does not develop properly. We will call it as aplasia cutis. And second one, they can cause choanal atresia. Choanal atresia. On the other hand, propylthiouracil, PTU, is not teratogenic. It is not teratogenic. Not teratogenic. And being not a teratogenic substance, it is the preferred agent. So it is preferred agent during first trimester of pregnancy. During first trimester of pregnancy. So if I have to give antithyroid drugs during the first trimester of pregnancy, my go-to drug is going to be propylthiouracil. Okay, and it is also a preferred agent during thyroid storm. During thyroid storm. Okay. So where do I use carbimazole, methimazole? These are my go-to drug for most of the patients. But if I'm dealing with someone who is already going through thyroid storm or is pregnant and is in the first trimester of pregnancy, for such patients, I will use propylthiouracil. Okay. Now, in the second or third trimester of pregnancy, I'm not using propylthiouracil. I'm switching back to methimazole or carbimazole. Why? Because PTU is hepatotoxic. And we all know that pregnancy itself is a hepatotoxic state. Right? There is something called as HELP syndrome, then acute cholestasis of pregnancy. There are a lot of liver dysfunctions happening during the pregnant state. Plus, add a hepatotoxic drug, things can go quite messy. So that's why in the second trimester we switch back to carbimazole or methimazole. Okay. Now, apart from these anti-thyroid drugs, we also use a second class of drugs, which is beta blockers. Why beta blockers are helpful? Because as I've already told you, many of the manifestations of thyrotoxicosis are mediated through sympathetic activation. So if I block the sympathetic activation, patient symptoms like the palpitations, atrial fibrillation, right, the the, the tremors that patients have, they all will come down. So they are helpful for controlling the sympathetic mediated symptoms, for controlling sympathetic mediated symptoms, mediated symptoms. What are those? Palpitations, hypertension, tremors, hypertension, tremors, they can all be controlled, including the ventricular rate in atrial fibrillation with the beta blockers. But if you ask me, what is the definitive treatment for Graves' disease or multinodal nodular goiter? Definitive treatment will be either I can give radioiodine therapy, radioiodine therapy. Okay, so then I will discuss that radioiodine therapy. And the second one is thyroidectomy. Thyroidectomy. Now, what side effects I would expect when I take up the definitive treatment? If I give radioiodine therapy, I'm ablating the thyroid gland. Means this radioiodine, once the patient takes it, it will go and get concentrated in the thyroid gland, because there is a iodine importer which will import a lot of iodine from the blood and trap it into the thyroid gland. And all this radiation is delivered to thyroid gland. So thyroid gland will get destroyed. Once the thyroid gland is destroyed, patient is no longer able to produce sufficient quantity of thyroid hormone. So from hyper, he will become hypothyroid. He will become hypothyroid. Okay. Now you may say, sir, we started to treat hyper, but we've ended up with hypothyroidism. Is it a good thing? Well, once he becomes hypothyroidism, what is the treatment that we give? Levothyroxine, right? So levothyroxine is far more safer than continuation of methimazole, carbimazole, or propylthiouracil. Okay, so that's why we are pushing him to be on a safer drug for rest of his life than be on more complex toxic drugs which are known to cause agranulocytosis, which can increase the risk of catastrophic infections and death. Similarly, thyroidectomy, we remove the thyroid gland. So then the production of thyroid hormone naturally will come down. Patient will become hypothyroid and she will depend on the thyroid hormone replacement. Okay. So that's about the hyperthyroidism. Now coming to one of the major complications of thyrotoxicosis, that is thyroid storm. What is it? Just like mixed edema coma is a severe form of hypothyroidism, thyroid storm is a severe form of hyperthyroidism or thyrotoxicosis. It's a life-threatening exacerbation of thyrotoxicosis. So what happens? There is sudden increase in the metabolic rate. So patient will end up developing features which are opposite to mixed edema coma. So here patients will start developing hyperthermia. So there we had hypothermia, here hyperthermia, right? There we had hypotension and bradycardia. Here we may end up with tachycardia or many a times with atrial fibrillation. And when we hyperstimulate the heart may end up failing. So we may end up developing heart failure. So there the neuronal activity was suppressed. So patient was going into coma. Here neuronal activity is enhanced by increased stimulation. So we may end up with seizures. So you can write opposite of what is written in the mixed edema coma as features of thyroid storm. Now, how will I manage these patients? How will I manage these patients? So for management of the thyroid storm, I need to give antithyroid drugs. I can use Lugol thiodine, beta blockers, and steroids. Okay. So among the antithyroid drugs, the one that is preferred is going to be propylthiouracil. Because of its rapid onset of action, propylthiouracil will be preferred, and it also inhibits the conversion of relatively less active thyroid hormone form to more active thyroid hormone form. Okay. Then we give Lugol thiodine after initiation of the antithyroid drugs, because what Lugol thiodine does, Lugol thiodine inhibits the thyroid hormone synthesis acutely, right? Then as we know, half of the symptoms of thyrotoxicosis are related to sympathetic activation, right? Why patient is having tachycardia, atrial fibrillation, heart failure, they're all because of sympathetic activation. So these symptoms can be taken care with the beta blockers. Here the preferred agent is going to be propranolol. And then adding corticosteroids, which also reduces the thyroid gland activity, suppresses the thyroid gland activity, can be helpful. Plus, in addition to that, we may need active cooling. If patient is in severe hyperthermia, active cooling may be required. There are various methods of active cooling, including rectal irrigation or bowel irrigation with the cold saline. All of that may be required to manage a case of thyroid storm. Okay. Now, once we have done with the thyroid gland, we will move to another important question, which is from the pituitary gland, variably discussed sometimes under electrolyte chapter, sometimes under endocrine. So we'll take it under endocrine. Write a short note on SIADH. This can be a 5-mark question, or sometimes it can be a 10-mark question where they ask you to define hyponatremia, discuss clinical features of hyponatremia, classify hyponatremia, and then write a short note on SIADH. So 5 marks for hypo part, 5 marks for SIADH. Okay. Now, the currently accepted terminology is not SIADH. We use the term SIAD, which refers to syndrome of inappropriate antidiuresis, not syndrome of inappropriate secretion of antidiuretic hormone. The term is syndrome of inappropriate antidiuresis. Okay. Now, to understand this, we need to understand how body regulates the water content in the body. How do we regulate the water content in the body? Okay, so just let me give you an example how we regulate the water content in the body. So let us say that I am dealing with a person whose serum osmolality. Normally our serum osmolality is tightly regulated. What is the range? Around 284 to 290. Let me write it as 280 to 290. Roughly, this is our serum osmolality, milliosmoles, 280 to 290 milliosmoles per liter. Okay. Now, whenever serum osmolality increases, right, let us say it has gone to more than 290. What does that mean at the biochemical level? When osmolality increases, either solutes are increased in number or water is decreased, right? So osmolality is nothing but a marker of concentration. So if osmolality increases, means either solute is increased or water is decreased, right? So either increase in the solute. The main solute is nothing but sodium, right? Sodium is the most osmotically active substance in the body. So either solute is increased or water is decreased. Now, body wants to correct this osmolality. So how can I correct? Can I correct this osmolality by increasing or decreasing the solute component? No. I do not have much choice with respect to regulation of solute. I may be able to regulate sodium, but there are a lot of other solutes in the blood which I will not be able to regulate. So the best way I can get the osmolality back to normal is by playing with the amount of water, right? So if water is decreased, I can increase the water, or even if solute and the osmolality get back to normal. So how can I increase the water? So to increase the water, I have two mechanisms. One is I can stimulate the thirst center. So body has a thirst mechanism. Whenever serum osmolality increases, body triggers the thirst mechanism. I drink more water and I get this osmolality corrected back to normal, right? Second, body produces antidiuretic hormone, which is also called as vasopressin. Now what this vasopressin is going to do? This vasopressin will go and act. From where it is coming? It is coming from the anterior pituitary gland, right? So from there it will go to the kidneys, and in the kidneys it will work on collecting ducts and distal convoluted tubules. In collecting duct and distal convoluted tubules, this will stimulate increased water reabsorption, acting through a receptor called as vasopressin receptors 2. And for water reabsorption, they use a channel called as aquaporin 2. So for vasopressin, here it is everything 2. The receptor is type 2, V2, and aquaporin is also type 2, AQP2. So once I increase the water, the plasma osmolality will by default come down, right? So that is how I end up correcting it. Okay. Now, if I have the converse of it, in the sense my osmolality has dropped down. Let us say osmolality has dropped down to less than 280, right? That means there is more water. There is increase in the water in the blood or there is decrease in the solute. Solute का तो मैं कुछ भी नहीं कर सकता हूँ. Whatever I can do is with water, right? So now body has to lose this water. So what natural adaptations I will expect the body to do? It will inhibit the thirst center. So I won't feel thirsty. I will reduce the intake of water. Second thing, the decrease in the serum osmolality should inhibit the release of ADH. So whenever serum osmolality decreases, what is the expectation from the pituitary gland? It should reduce the ADH. It should reduce the ADH. What we learn from here? If serum osmolality decreases, what should happen to ADH? ADH should also decrease. And if serum osmolality increases, what should happen to ADH? ADH should also increase. So can I say that the serum osmolality and ADH both go in the same direction? Osmolality is going high, means water is going less in the body. So ADH will come, it will also go high, help you to gain more water so that osmolality gets back to normal. As the osmolality gets back to normal, ADH will also get back to normal. This is normal physiology. Now let us say that I've got a patient who has developed hyponatremia. That means the solute is down. Solute is down means osmolality will be down. In such cases, I expect the ADH to go down, right? The expectation is that the ADH will go down. But in some individuals, it doesn't go down. And if ADH doesn't go down, what will happen? We will continue to reabsorb more and more water. We will go on diluting the plasma and hyponatremia will go on getting worsened. So that is what happens in patients with SIADH or SIAD, where despite having hyponatremia or hypoosmolality of the plasma, ADH is not getting suppressed. That's why it's called as inappropriate antidiuresis. Inappropriate antidiuresis. So coming back to the definition, what is SIADH? SIADH refers to a syndrome in which ADH activity is not suppressed despite plasma hypoosmolality. Normal expectation, what did I tell you? Serum osmolality and ADH go in the same direction. Osmolality increasing, ADH increases. Osmolality decreasing, ADH decreasing. But in SIADH, osmolality decreased, but ADH is not decreasing appropriately, right? So that's why it is an inappropriate response from the ADH, a syndrome in which ADH activity is not suppressed despite plasma or hypoosmolality. So causes or resulting in right increased water reabsorption by kidneys, and when I reabsorb too much water, I am diluting the plasma, which will lead to dilutional hyponatremia. So all the symptoms of my SIADH are going to depend on hyponatremia, right? So there will be dilutional hyponatremia. Whatever patients of SIADH I'm going to recognize because they have symptoms of hyponatremia. Okay. Now under what circumstances my gland can behave this way, where I can have SIADH? It can happen when someone is having head injury. Certain drugs like tricyclic antidepressants, selective serotonin reuptake inhibitors, vincristine, carbamazepine, they can cause pneumonia, and I forgot to mention the lung cancer can cause, meningitis can cause, and brain abscess can cause. So when I look at this, what do I learn? I learn that majority of the causes are either related to respiratory problems or brain problems or drugs. So you can simply say lungs, brain, and drugs. These are the three abnormalities which can cause SIADH. Among them, respiratory causes are the most common cause, followed by the neurological causes are the second most common cause. Drugs are relatively less common cause. Okay. Now, what clinical features a patient of SIADH will present? All clinical features of SIADH are due to hyponatremia. They are due to hyponatremia. Okay, so now what hyponatremic symptoms we can expect? So whenever we have mild hyponatremia, what symptoms do I get? And then moderate hyponatremia, severe hyponatremia. Why hyponatremia affects the brain? Anybody has an idea? See, when we have hyperkalemia, hypokalemia, it affects cardiac muscle and the skeletal muscle function. But when we have abnormalities of sodium, it affects brain. Why? We just learned that sodium is the most important osmotically active substance in the body, right? We have to learn one more thing. If I have water in two compartments, okay, in one compartment there is too much of solute, right? In another compartment there is less solute. So this is hypoosmolar compartment, right? And this is hyperosmolar. Body will, of course, not just the body, the physics says that the systems will try to maintain the isoosmolarity. How can I maintain the isoosmolarity? Either I have to shift solute from hyperosmolar to hypoosmolar, or shift water from hyper to hypo, so that this becomes diluted and both become isoosmolar. What nature favors? Nature favors movement of water from hypo to hyperosmolar compartment. Hypo to hyperosmolar compartment. Okay, now think about it. If my blood sodium is low, so what is happening to the blood osmolality? It is low, right? Remember, the most important osmotically active substance in the body is sodium. If sodium is low, blood osmolality or plasma osmolality is low. So in comparison to that, right, now you can say your blood is in this state. In comparison to that, our neurons are relatively hyperosmolar. They are physiologically osmolar, but in comparison to our plasma, they are more hyperosmolar. So water will move from plasma to neurons. When water enters into the neurons, what do we call it as? We will call it as cerebral edema. So hyponatremia causes cerebral edema. Why? Because plasma or blood is hypoosmolar. Your brain, in comparison, is hyperosmolar. So water is moving from blood to the brain tissue. So brain tissue is becoming edematous, and cerebral edema leads to all the CNS manifestations that we talk when it comes to hyponatremia. So when it is mild, it may not cause many symptoms. Patients may be asymptomatic, or they can have just mild lethargy or fatigue. When it is moderate, right, they can start noticing cramps, fatigue. But when it becomes severe, right, so they can start becoming drowsy, right, or comatose, or it can even lead to death. All the manifestations, right, remember, hyponatremia causes cerebral edema. So all the manifestations are related to cerebral edema. So if I get a patient, right, how do I work up for the diagnosis? If I'm suspecting that it may be a case of SIADH. First thing is that I have to confirm that they have got hyponatremia, and then I have to confirm that this hyponatremia is indeed because of SIADH. Then I have to search for the cause for SIADH. So in terms of evaluation, first I have to confirm that there is hyponatremia, that is serum sodium less than 135 millimoles per liter. Normal is 135 to 145. Second, SIADH causes what we call as euvolemia. Means in SIADH there will be no edema, right? No decrease in the jugular venous pressure, or no decrease in the skin turgor. Means there is no sign of dehydration or fluid overload. It's a euvolemic state. Okay. Now, euvolemic hyponatremia can be caused by three conditions. One of them is SIADH. Second, I think someone had commented that in mixed edema, yes, in severe hypothyroidism, we can get hyponatremia, and also in cortisol deficiency or hypocortisolism. So I have to rule out hypothyroidism and the hypocortisolism before I come to the conclusion that this is a case of SIADH. So for that, there is a well laid out diagnostic criteria which is called as Barter and Schwartz criteria. Barter and Schwartz criteria. So what the criteria says, the first essential requirement for the diagnosis of SIADH, for SIADH, the serum sodium should be less than 135 millimoles per liter to say that there is hyponatremia. The second one is serum osmolality. Why serum osmolality is part of the criteria? Because hyponatremia, if it is truly rare, the serum osmolality has to be low because sodium is the most important determinant of serum osmolality. So it should be less than 280 milliosmoles per liter. Milliosmoles per liter. So if I have someone with sodium low but serum osmolality is normal or high, it means patient has pseudo hyponatremia. Patient has pseudo hyponatremia. It may be laboratory error or presence of other osmotically active substances like glucose may be the reason. Okay, so this is primarily introduced to rule out pseudo hyponatremia. Pseudo hyponatremia. Okay, then the third thing that we have after this, we have to look at the serum, the urine osmolality. We have to look at the urine osmolality. Now suppose there is a patient with hyponatremia and he does not have SIADH. For some other reason he has hyponatremia. So in that case, ADH will be functioning as expected. So in such case, what do you expect the urine to be? Urine should be diluted or concentrated. Let us say that there is decrease in the serum osmolality because of hyponatremia and our ADH is doing as expected. What is it supposed to do? Decrease or get suppressed. So if there is suppression of ADH, then what will happen to the reabsorption of water at the kidney? It will be inhibited, right? Because ADH, antidiuretic hormone, it facilitates reabsorption. ADH gets suppressed, reabsorption stops, and I will start losing this water in the urine. So if I lose water, more and more water in the urine, my urine will be concentrated or diluted. It will be concentrated or diluted. It will be very much diluted, right? Urine osmolality will be very, very low. But if I'm not able to do that, ADH is still active. So it is going and stimulating the kidneys to reabsorb. So then I'm excreting relatively concentrated. Ideally, in presence of hyponatremia, expectation is that I will throw out dilute urine. But here I will be throwing out concentrated urine. That means urine osmolality will be high, more than 100 milliosmoles. If it is suppressed, it should be less than 100 milliosmoles. The fourth is urine sodium. So if my urine is getting concentrated, urine sodium will be high, right? Urine sodium more than 30. Some books mention 20. Original Barters and Swart had 20 only. 20 millimoles per liter. Okay, there is a fifth criteria. The fifth criteria is normal. I forgot to mention even equally important. Clinically, patient should be euvolemic. And the last criteria is normal TSH and cortisol values, just to rule out the other causes for euvolemic hyponatremia. So when these criteria are met, it is a case of SIAD or SIADH. Now once I have established that this patient is having inappropriate response from the ADH, when it is supposed to be suppressed, it is not suppressed, it is reabsorbing a lot of water, diluting the plasma, causing hyponatremia, and now I have to manage it. So if I have to manage it, what should I do? There are two ways I can get the patient's sodium levels normalized. One is add more sodium or remove water, right? In both cases, the concentration can be balanced either by adding more sodium or removing water. What is the step that we should follow first? What is the main problem? Retaining more water, right? So I'll try to remove more water. And one of the simple step I can take is fluid restriction. Restrict the fluid intake. Fluid restriction to less than 1 liter per day. So that is the general principle that is followed for all patients, especially when it is mild. But if that is not helping or not adequate, I have to think of pharmacological treatment. So now what choices I have for pharmacological treatment of SIADH? ADH is going and stimulating the kidney to reabsorb water unnecessarily. Can I block it? Yes, we have drugs which can block the action of ADH on the kidneys, right? So we have vasopressin antagonists or V2 receptor blockers. V2 receptor blockers. What are the examples we have? We have tolvaptan and conivaptan. Tolvaptan is available as per oral preparation, and we have conivaptan available as IV preparation. Okay. What else I can do? I can give hypertonic saline. Instead of blocking the water reabsorption, I can give hypertonic. I can give a lot of sodium can be added to the system, right? So we'll call it as hypertonic saline, which is usually 3% sodium chloride. Hypertonic saline of 3% sodium chloride. Now, what should I choose depends on the circumstances. What should I choose? Right. So if it is mild hyponatremia, the mainstay of treatment is going to be fluid restriction, because remember, mild mostly they are asymptomatic or they will have some vague fatigue, lethargy. So it is mainly treated with fluid restriction. If I have moderate hyponatremia, if it is moderate hyponatremia, what I can do? If it is moderate hyponatremia, we can prefer giving them V2 receptor antagonists, right? Tolvaptan or conivaptan. And if it is severe hyponatremia, remember, any patient who has severe hyponatremia should always be treated with hypertonic saline, right? So 3% sodium chloride is the treatment of choice for severe hyponatremia. Don't waste your time giving tolvaptan or fluid restriction. That alone is not adequate. Especially in patients with moderate to severe hyponatremia, we have to remember that rate of hyponatremia correction should not exceed 8 to 12 millimoles in 24 hours. So if within 24 hours I correct sodium by more than 12 millimoles, there is a high risk, because this is associated with increased risk of a complication called as osmotic demyelination, which is also called as, because it affects most commonly the pons, it is also called as central pontine myelinosis, which can cause quadriplegia, or what we call as locked in syndrome. So we should always be aware of it. Means, what is the meaning of this statement? That is starting 3% saline for a severe hyponatremia case. Morning serum sodium is 110. So by tomorrow, it should not become more than 122, right? The maximum I can reach is 122. So by tomorrow, if it is more than 122, that means I am overcorrecting. I am correcting much faster, and the patient may end up with the central pontine myelinosis or osmotic demyelination, right? So that's about our SIADH management. Okay, I think we are running out of time. So there are a few more questions that we need to discuss, but of course for that we will need another 2 hours to discuss the adrenal disorders. So what we will do is I will ask the team to schedule one session on the endocrine for the adrenal disorders, and as you requested, one more session on the hematology. We need to sneak in the time a little bit, because other subject sessions are also going to run parallel. So within this week span, I will try to sneak in the 2 sessions, and we will complete the hematology questions as well as the adrenal gland related questions from the endocrine. So for today, I'll sign off. I'll see you in the next class. Whenever it is scheduled, I will share it on the Telegram, and we will probably will also announce it through the PW's Telegram channel and Instagram, right? Okay, so that's it from me today, guys. I'll see you soon. The notes will be available as usual on the PW's Telegram channel. I'll see you soon. And let me know if you want any specific questions or any specific topics to be discussed. I will try to accommodate in the 2 sessions that I'm going to ask the team to.